Good day, esteemed colleagues and dedicated primary care physicians. Today, we embark on an insightful journey into the world of otitis, a common yet often nuanced condition we frequently encounter in our clinical practice. Imagine a young child tugging at their ear, an adult expressing discomfort before a long-awaited vacation involving air travel or scuba diving, or a patient puzzled by persistent ear fullness and diminished hearing. These scenarios highlight the importance of our role in effectively diagnosing and managing otitis to alleviate discomfort and prevent complications. The prevalence of otitis in primary care. Otitis, particularly otitis media, is one of the most common ailments we address, especially in pediatric settings. While adults are less frequently affected, they are not immune to its discomforts. Symptoms can range from a subtle sense of fullness to acute pain, often accompanied by hearing impairment. Patients may seek our guidance out of concern for activities like flying or diving, especially if over-the-counter remedies have failed to provide relief. Our objective today is to deepen our understanding of otitis, focusing on its pathophysiology, clinical presentations, diagnostic approaches, and evidence-based management strategies. This comprehensive overview will enhance our ability to provide optimal care to our patients. Pathophysiology and clinical presentation. Acute otitis media, the middle ear's tail. Pathophysiology. Acute otitis media, AOM, typically arises from dysfunction of the eustachian tube, leading to impaired ventilation of the middle ear. This dysfunction can result from eustachian tube obstruction, caused by mucosal edema due to viral upper respiratory infections or allergies. Reflux of nasopharyngeal secretions allows pathogens to enter the middle ear, which is normally sterile. Common pathogens: bacterial, Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis. Viral agents often precede bacterial infection, causing serous otitis media. Clinical features: ear pain. Otalgia ranges from mild discomfort to severe pain. Hearing loss, conductive hearing impairment due to fluid in the middle ear. Fever, usually mild to moderate. Otoscopic findings: bulging tympanic membrane, due to fluid accumulation. Loss of bony landmarks. The malleus becomes less visible. Impaired mobility, assessed using pneumatic otoscopy. Purulent effusion indicates bacterial infection, may lead to spontaneous perforation and otorrhea. Complications: recurrent AOM. Multiple episodes within a short period. Chronic otitis media, persistent inflammation leading to tympanic membrane perforation. Serous otitis media, non-infectious fluid persists in the middle ear. Acute serous otitis media, the silent accumulation, often follows eustachian tube dysfunction without bacterial infection. Clinical features: fullness in the ear. Patients may describe a feeling of blockage. Hearing loss, due to fluid accumulation. Otoscopic findings: retracted tympanic membrane, negative pressure in the middle ear. Translucent effusion, fluid visible behind the tympanic membrane. Presence of bony landmarks. Unlike in AOM, landmarks remain visible. External otitis, the outer ear's inflammation, also known as swimmer's ear. External otitis is an inflammation of the external auditory canal. Pathophysiology: skin breakdown, from trauma, e.g., fingernails, cotton swabs, or excessive moisture. Infection: bacterial, e.g., Pseudomonas aeruginosa, Staphylococcus aureus, or fungal organisms. Clinical features: ear pain, exacerbated by movement of the pinna or tragus. Itching and redness, due to inflammation. Discharge may be purulent or serous. Swollen ear canal can lead to conductive hearing loss. Malignant, necrotizing, external otitis, a severe threat, a severe infection seen primarily in immunocompromised individuals and elderly diabetics. Pathophysiology: invasive infection, usually caused by Pseudomonas aeruginosa. Spread to surrounding tissues, including bone, osteomyelitis of the skull base. Clinical features: severe ear pain, disproportionate to clinical findings, purulent discharge, often persistent, granulation tissue, visible in the ear canal, cranial nerve involvement, facial nerve palsy may occur, chronic otitis media. The persistent challenge results from unresolved or recurrent AOM leading to long-term changes. Clinical features: chronic otorrhea, foul-smelling discharge, hearing loss due to tympanic membrane perforation or ossicular damage, otoscopic findings, perforated tympanic membrane, central or marginal. Possible cholesteatoma, accumulation of keratinized debris. Diagnostic approaches: unveiling the cause, clinical diagnosis, history and physical examination, symptom inquiry, duration, severity, associated symptoms, fever, hearing loss, risk factors, recent upper respiratory infections, allergies, water exposure, trauma, otoscopic examination, essential for visualizing the tympanic membrane and ear canal, pneumatic otoscopy, assess mobility. Helps differentiate between AOM, reduced mobility, and serous otitis media, retracted membrane, when to consider additional tests. Tympanometry evaluates middle ear function, especially in children. Cultures, not routinely performed but may be necessary in chronic cases or immunocompromised patients. Imaging studies: CT scan of temporal bone, if complications like mastoiditis or cholesteatoma are suspected. Management strategies: healing the ear, acute otitis media, treatment objectives, relieve pain, eradicate infection, prevent complications, analgesia, acetaminophen or ibuprofen, for pain and fever control, antibiotic therapy, first line. Amoxicillin 80 to 90 mg/kg/day in divided doses for children, standard dosing for adults. Duration: typically 5 to 10 days. Alternatives: if allergic to penicillin or in cases of resistant organisms, amoxicillin clavulinate, cephalosporins, e.g., cefdinir, macrolides, e.g., azithromycin, observation option, in select cases of mild AOM in children over 2 years. Watchful waiting for 48 to 72 hours may be appropriate. Adjunctive therapies, decongestants, limited evidence of benefit, may be considered for eustachian tube dysfunction. Avoid antihistamines, can thicken secretions and impede drainage. Acute serous otitis media. Management: watchful waiting, often resolves spontaneously. Decongestants may aid in eustachian tube function. Autoinflation techniques: Valsalva maneuver to help equalize pressure. No antibiotics, unless bacterial infection is suspected. External otitis, treatment objectives: eliminate infection, reduce inflammation, restore normal canal environment. Topical therapy: acidifying solutions, acetic acid drops to restore normal pH, antibiotic ear drops, combination drops, containing antibiotics and corticosteroids, e.g., ciprofloxacin with hydrocortisone. Dosing: typically 4 drops. 3 to 4 times daily for 7 to 10 days. Pain management: analgesics, oral medications as needed, avoidance of water exposure, use protective measures during bathing or swimming. Ear canal wick may be necessary if swelling prevents medication from reaching the infected area. Malignant external otitis, urgent management required, hospitalization, for close monitoring and aggressive treatment. Systemic antibiotics, antipseudomonal agents, for ciprofloxacin is the drug of choice. Debridement, surgical intervention may be necessary. Blood glucose control, essential in diabetic patients. Chronic otitis media, management objectives: control infection, restore hearing, prevent complications. Medical management: oral toilet, regular cleaning of the ear canal. Topical antibiotics, as in otitis externa, but tailored based on culture results if available. Surgical intervention: tympanoplasty, repair of the tympanic membrane, mastoidectomy, if mastoid air cells are involved, cholesteatoma removal, essential to prevent further destruction. Patient education, empowering our patients, general advice, prompt medical attention, encourage patients to seek help early when symptoms arise, medication adherence, importance of completing antibiotic courses, avoid insertion of objects, educate against using cotton swabs or other objects in the ear canal, water precautions, preventing moisture. Use earplugs or a cotton ball coated with petroleum jelly during water exposure. Drying the ear canal, gently towel dry the outer ear after swimming or bathing. Air travel tips, decongestants, used before flying to reduce eustachian tube edema. Equalization techniques, chewing gum, swallowing, or yawning during ascent and descent. When to refer, collaborating with specialists, indications for otolaryngology referral, refractory AOM, no improvement after appropriate medical therapy, chronic otitis media, persistent symptoms or structural damage, complications, signs of mastoiditis, facial nerve palsy, or vertigo, suspicion of cholesteatoma, requires surgical evaluation, malignant external otitis, emergent referral for aggressive management. To deepen our understanding of otitis media and its various presentations, let's delve into real-life case studies that illustrate the complexities and nuances of diagnosing and managing this common condition. Through these clinical scenarios, we will explore different types of otitis media, their diagnostic challenges, management strategies, and outcomes. Case Study 1: Acute otitis media in a young child. Patient profile: name, Emily, age, 2 years old, gender, female, history, brought to the clinic by her mother with complaints of ear pain and fever. Clinical presentation: chief complaint, ear pulling and crying for the past 2 days. Low-grade fever noted at home. History of present illness. Emily developed a runny nose and cough 3 days ago. Symptoms progressed to irritability and poor sleep. Mother reports decreased appetite and difficulty feeding. Past medical history: no significant medical history. Up to date on vaccinations. Family and social history: attends daycare. No known exposure to sick contacts beyond usual daycare environment. Physical examination: vital signs, temperature 38.5 degrees Celsius 101.3 degrees Fahrenheit, heart rate 110 beats per minute, respiratory rate 24 breaths per minute, blood pressure 90/60 mm Hg, general appearance irritable but consolable toddler, mildly lethargic. Ear examination: right ear, tympanic membrane is bulging and erythematous. Loss of normal landmarks, light reflex absent. Decreased mobility on pneumatic otoscopy. Left ear, tympanic membrane appears normal with visible landmarks. Other systems: nasal congestion with clear rhinorrhea. Throat mildly erythematous without exudates. Lungs clear to auscultation. Diagnosis: acute otitis media, AOM, of the right ear. Management: 1. Pain and fever control: acetaminophen, 15 mg per kilogram every 4 to 6 hours as needed for fever and pain. 2. Antibiotic therapy: amoxicillin, 80 mg per kilogram per day divided every 12 hours. Dosage calculation: for a 12 kg child, 960 mg per day divided into 2 doses of 480 mg each. Duration: 10 days. 3. Patient and parent education: importance of completing the full course of antibiotics. Monitoring for improvement over the next 48 to 72 hours. Signs to watch for that would necessitate immediate medical attention, e.g., worsening symptoms, high fever, decreased responsiveness. 4. Follow-up: scheduled in 2 weeks to reassess ear status and ensure resolution. Outcome: at follow-up visit. Mother reports Emily is back to her usual playful self. Fever resolved within 2 days of starting antibiotics. Eating and sleeping patterns have returned to normal. Physical examination: Right tympanic membrane appears normal with slight residual erythema. Good mobility on pneumatic otoscopy. No signs of effusion. Discussion. Key learning points. High-dose amoxicillin. Recommended first-line treatment for AOM in children due to increasing resistance patterns. Pain management. Essential component of treatment to ensure comfort and compliance. Daycare attendance. Increases risk of upper respiratory infections and subsequent AOM. Follow-up. Important to confirm resolution and assess for potential complications or persistent effusion. Case Study 2. Recurrent otitis media with effusion in a preschooler. Patient profile. Name, Michael. Age, 4 years old. Gender, male. History. Referred by pediatrician for recurrent ear infections and speech delay. Clinical presentation. Chief complaint, persistent hearing difficulties and unclear speech. History of present illness. Michael has had 4 episodes of otitis media in the past 6 months. Parents notice he often does not respond when called and frequently says, "What?" or "Huh." Speech is not as developed as peers. Past medical history, full-term birth without complications. Developmental milestones delayed in speech. Family and social history, lives with parents and older sibling. No significant family history of hearing loss. Physical examination, vital signs, within normal limits. Ear examination, both ears, tympanic membranes are dull and gray. Presence of air fluid levels behind the tympanic membranes. Limited mobility on pneumatic otoscopy. No signs of acute infection. Audiometry testing, conductive hearing loss bilaterally. Hearing thresholds at 30 dB across frequencies. Diagnosis, chronic otitis media with effusion, OME, associated speech delay. Management 1. Referral to otolaryngology, ENT specialist, for further evaluation and management. 2. Possible interventions, tympanostomy tube insertion, to ventilate the middle ear and prevent fluid accumulation. Adenodectomy, considered if adenoidal hypertrophy is contributing to eustachian tube dysfunction. 3. Speech therapy, initiated to address speech delay. 4. Parental counseling, education about the condition and the benefits and risks of surgical intervention. Importance of follow-up appointments. Outcome, post-surgery, tympanostomy tube successfully placed. Middle ear effusion resolved. Hearing tests show improvement to normal thresholds. At 6-month follow-up, significant improvement in speech articulation. Parents report better responsiveness and engagement. Discussion, key learning points, chronic OME, can lead to conductive hearing loss and impact speech development. Early intervention. Crucial to prevent long-term developmental delays. Multidisciplinary approach. Collaboration between primary care, ENT specialists, and speech therapists enhances patient outcomes. Monitoring. Regular audiometric evaluations are important in children with recurrent OME. Case Study 3. Acute otitis media in an adult with upper respiratory infection. Patient profile. Name, Sarah. Age, 35 years old. Gender, female. Occupation, flight attendant. Clinical presentation. Chief complaint, severe left ear pain and decreased hearing for 3 days. History of present illness, developed symptoms of a common cold 1 week ago, nasal congestion, sore throat, and cough. Ear pain started during a flight descent and has worsened. Describes a sensation of fullness and muffled sounds. Over-the-counter decongestants provided minimal relief. Past medical history, no chronic medical conditions. No prior history of ear infections. Family and social history, non-smoker. Occasional alcohol use. No family history of ear diseases. Physical examination, vital signs, temperature, 37.2 degrees Celsius 99 degrees Fahrenheit, heart rate, 80 beats per minute, blood pressure, 120/75 mmHg, ear examination, left ear. Tympanic membrane is erythematous and bulging. Bony landmarks obscured. No perforation noted. Decreased mobility on pneumatic otoscopy. Right ear, tympanic membrane normal. Nasal examination, mucosal edema with clear rhinorrhea. Diagnosis, acute otitis media of the left ear. Secondary to eustachian tube dysfunction. Management. 1. Pain management, ibuprofen, 400 mg every 6 hours as needed. 2. Antibiotic therapy, amoxicillin clavulanate, 875 mg per 125 mg twice daily for 10 days. Chosen due to severe symptoms and need for broader coverage. 3. Adjunctive therapies, oral decongestants, pseudoephedrine 60 mg every 6 hours as needed. Nasal steroid spray, fluticasone propionate 1 spray each nostril daily to reduce mucosal inflammation. 4. Patient education, avoid flying until symptoms resolve to prevent barotrauma. Techniques to equalize ear pressure, e.g., Valsalva maneuver. 5. Follow-up, reevaluate in 1 week or sooner if symptoms worsen. Outcome, at 1 week follow-up, ear pain significantly reduced. Hearing improved. Tympanic membrane appears normal with restored mobility. Return to work, advised she can resume flying duties. Discussion, key learning points. AOM in adults. Less common but can be associated with complications due to barometric pressure changes during air travel. Eustachian tube dysfunction, contributing factor in AOM. Decongestants and nasal steroids can aid in symptom relief. Activity modification. Important to prevent worsening of symptoms or complications. Antibiotic selection. Amoxicillin clavulanate provides coverage for potential resistant organisms in adults. Case Study 4. Malignant otitis externa in a diabetic patient. Patient profile. Name, Mr. Johnson. Age, 68 years old. Gender, male. History, presence with severe ear pain unresponsive to standard treatments. Clinical presentation. Chief complaint, left ear pain for 2 weeks, progressively worsening. History of present illness, pain described as deep and severe, worse at night. Purulent discharge from the ear. Notice decreased hearing on the affected side. Over-the-counter analgesics and antibiotic ear drops have not provided relief. Past. Medical history. Type 2 diabetes mellitus for 15 years, poorly controlled, HbA1c 9%, hypertension. Physical examination, vital signs, temperature, 38.8 degrees Celsius 101.8 degrees Fahrenheit, heart rate, 95 beats per minute. Blood pressure, 140/85 mmHg, ear examination, left ear, external auditory canal is swollen with granulation tissue at the bony cartilaginous junction. Purulent, foul-smelling discharge. Severe pain upon manipulation of the tragus and pinna. Cranial nerve examination, weakness noted in the muscles of facial expression on the left side, facial nerve involvement. Laboratory studies, elevated white blood cell count, blood glucose, 250 mg per deciliter. Imaging, CT scan of temporal bone, evidence of bony erosion of the temporal bone. Diagnosis, malignant, necrotizing, otitis externa. Management. 1. Hospital admission, for intensive treatment and monitoring. 2. Systemic antibiotic therapy, intravenous ciprofloxacin, 400 mg every 12 hours. Antipseudommonal coverage is critical. 3. Glycemic control, initiated insulin therapy to manage hyperglycemia. 4. Pain management, intravenous analgesics as needed. 5. ENT consultation. For possible surgical debridement. Close monitoring of cranial nerve function. 6. Microbiology, cultures obtained from ear discharge to guide therapy. Outcome. During hospital stay, pain gradually decreased. Blood glucose levels stabilized. Ear cultures confirmed Pseudomonas aeruginosa sensitive to ciprofloxacin. After 2 weeks, transition to oral ciprofloxacin 750 mg twice daily. Facial nerve function began to improve. At 6-week follow-up, complete resolution of infection. Facial nerve function returned to baseline. Continued monitoring for recurrence. Discussion, key learning points, high index of suspicion. Necessary for early diagnosis in diabetic patients presenting with severe ear pain. Prompt treatment. Aggressive antibiotic therapy is essential to prevent serious complications. Multidisciplinary approach, involving endocrinology for diabetes management and ENT for possible surgical intervention. Monitoring. Long-term follow-up is important due to risk of recurrence. Case Study 5. Otitis Media with effusion in an adult due to nasopharyngeal Massachusetts. Patient profile. Name Mr. Lee, age 50 years old, gender male, occupation office worker, clinical presentation, chief complaint persistent feeling of fullness in the left ear and hearing loss for 3 months. History of present illness, no pain or discharge. Occasional tinnitus in the affected ear. Over-the-counter decongestants ineffective. Past medical history smoker, 1 pack per day for 30 years. No history of allergies or frequent infections. Physical examination, vital signs, within normal limits. Ear examination, left ear, tympanic membrane appears dull with an effusion. Mobility decreased on pneumatic otoscopy. Right ear, normal findings. Nasal examination, possible nasal obstruction on the left side. Additional findings, palpable cervical lymphadenopathy on the left side. Diagnosis, unilateral otitis media with effusion, OME, suspicious for nasopharyngeal pathology. Management, 1. Referral to ENT specialist, urgent referral for nasopharyngeal examination. 2. Diagnostic workup, nasopharyngoscopy, reveal the mass obstructing the eustachian tube opening on the left side. Biopsy of mass, histopathology confirm nasopharyngeal carcinoma. 3. Imaging studies, MRI and CT scans, assess extent of the tumor and involvement of adjacent structures. 4. Multidisciplinary treatment plan. Oncology consultation. Plan for radiotherapy and chemotherapy. Outcome, treatment course, underwent combined chemoradiotherapy. Tympanostomy tube placed to alleviate middle ear effusion. Follow-up, improvement in ear symptoms. Ongoing monitoring for tumor response. Discussion, key learning points, unilateral OME in adults, should raise suspicion for nasopharyngeal tumors, especially in high-risk populations. Risk factors, smoking and certain ethnic backgrounds increase risk for nasopharyngeal carcinoma. Early detection, critical for improving prognosis and malignancies. Comprehensive evaluation, and treatments fail. Conclusion: these case studies highlight the diversity of otitis media presentations across different age groups and underlying conditions. They emphasize the importance of accurate diagnosis, through thorough history-taking and physical examination, appropriate management, tailoring treatment to the individual patient's needs, patient education, ensuring understanding of the condition, treatment plan, and importance of follow-up, collaboration, working with specialists when necessary to provide comprehensive care. By learning from real-life scenarios, we enhance our clinical acumen and are better prepared to manage the complexities of otitis media in our practice. Thank you for your attention and engagement throughout this lecture. Your dedication to advancing your knowledge and providing the best care for your patients is truly inspiring. If you found this presentation insightful and enriching, we invite you to like, subscribe, and become a part of our growing community of healthcare professionals. By staying connected, you'll have access to more in-depth lectures, real-life case studies, and valuable resources designed to support your journey in primary care. Together, let's continue to learn, grow, and make a positive impact on the health and well-being of our patients.